demonstration, I wanted to let you know that you can go to this Confluence site, which I will just take this link and stick that in chat so that if anybody doesn't want to have to worry about navigating. Did it go? Let's see. You can go out to the agenda today and there we go. You can go out to the agenda today and on the line in the row in the table for this session, there's a zip file that has all the handouts. There's a separate zip file for the ECW document that we'll be reviewing. And you'll also get the copy of this presentation and some other reference materials, basically the background specs that we used to prepare the work. During the oh, I wanted to mention that this Excel sheet is all of the synthetic patient data from the scenario, everything that we kind of built leading up to this, but I've also added 2 new tabs where you can record, kind of take your notes as we go. I set that up for you so it's super easy to have spots to record stuff in the order that we're going through it. When we get to the review, this is going to be the hardest part. And so we're going to just focus on a couple key things looking at in the header of the document, 3 spots where we'll stop along the way, and then we'll go into the structured body. We'll spend most of our time looking at the pregnancy section, both for the current pregnancy and past pregnancy information for Mimi, our mammy, I guess, our sample patient. We'll take a very quick high-level look at some of the other sections of information that are included in this progress note, the antepartum summary progress note. And then if there's time, we'll just take a quick look at the vital signs section, something to point out there. This just kind of depends on how much time we have, how far we go. For the insight sharing, this is why I'm suggesting that you open that Excel spreadsheet. I already made 2 tabs. One tab to kind of go along with the document exchange part that Richard and Eric will be demonstrating, where I put some questions that you can answer with short yes, no answers, or you can take some longer notes about them. And then this matches with the pathway that we'll take through the deeper dive into the document. And there's room in here where you can, sort of score if you think the human readable is meeting or somewhat meets or doesn't meet what is required. Same with the machine processable. So I set that spreadsheet up for you to take notes really easily right in there. You guys can be downloading the materials, and I am going to stop sharing and invite Richard from ECW to lead off with some description of what ECW has been doing in support of this track and just kind of walk us through the experience of creating the CDA document and sending it to Epic in a direct message. Richard?
Thanks, Lisa. Good morning, everyone. My name is Richard, and I'm from the product management team at eClinicalWorks. I've been working with Lisa the past couple of days, trying to get the antepartum C-CDA document, just building that document and trying to get it over to the direct address that I was given. So yeah, talking about the document, the C-CDA document. So today, we have a workflow through the Commonwealth Care Quality to provide a PDF format of an OB flow sheet when the request comes in. But again, that's a PDF that's in the non-structured C-CDA document format. But I think the ask is to basically have the data discretely available in a structured C-CDA. So, it can be consumed on the receiving end. So we've been working on that document, and based on the guidelines we've received from Lisa, we've tried to build a document. Again, not the final document, it obviously needs some further reviews, but um, I can start um, showing you what we have currently, and then we can get into discussions as Lisa drives this.
That's
Lisa, do you want me to show the XML document I shared with you, or I don't know?
You can whatever, feels like it makes a sense. We're gonna delve into it in the next half an hour. I think, being able to see maybe what your sandbox environment looks like so people can imagine the environment that Samantha would be working in and how the document gets produced and
I see.
what needs to happen to send it somewhere.
I see.
Or maybe even if you have the PDF that you make today, how it compares with what the CDA document looks like.
Okay. Um, yeah, maybe I can show you what happens in eClinicalWorks, and then we can talk through
That'd
the
be
doc.
great.
Yeah, sounds good. Um, I'm sharing my screen. Let me know once you guys see it.
Not yet. I still just see your name.
I see. Okay. Can you guys see it now?
Yes.
Yep.
Okay, cool. All right. So basically, what you're seeing on the screen is the ClinicalWorks application, the EHR. Um, so I'm just going to take you to the OB flow sheet, is what we call, where pregnancy data gets documented. Then we can talk through the different data points. All right. So this is basically how the OB flow sheet looks um, once it loads. Yeah. So what I have currently is an OB flow sheet where the top part is just the headers telling you what the gravida is, what the parameters are, and some other information. Um, so this is basically what I don't know, Samantha or someone who's using eClinicalWorks would be looking at when they document OB data. So a couple of data points is basically we have a section called EDD where users would document their initial dates, like when was the ultrasound done, what was the LMP, and stuff like that. And they would basically go to Form A. That's where you would have details about the total number of pregnancies or how many births, how many premature, and LMP dates and whatnot. So yeah, so this is basically the screen where users would document the OB data, and based on the ask, what might happen is this data that was documented, and as people um, and as users document data for the first trimester, second trimester, third trimester, so whatever data is documented here would end up showing up in the antepartum C-CDA document that we would be generating. And I think based on yesterday's discussion, my understanding is first we would have two workflows. The first workflow is for someone to be able to send this out to a direct address. And the second is maybe phase two would be where we would have this in the common care quality um, workflows where a query based request is um, responded to, where the same document would be provided based on the data we have at that point. So yeah, so this is the UI where users document data. And once that um, once that C-CDA document is generated, that's when you would see a C-CDA document showing up similar to this. Um, and yeah, the consumer would be consuming this document and then getting whatever data they need.
Is that screen, Richard, is that screen actually accessible that somebody like Samantha would be exposed to seeing the CDA document, or did you just switch out, they would never see, or would they ever see what the CDA document looks like?
Um, Depends. I mean, if that's the requirement, we can have that capability. But I
Mm-hmm.
think
Right, but you're showing the XML. That's a software tool
That's
that's
in a different,
representing.
that's in a
Yeah,
different, a different
right,
interface. So how
right.
does the user ever know or see that a CDA document gets created, or do they just like press a button that says, send this to Texas Regional?
right. So that's what we have scoped for now, saying they'll have a button somewhere bottom here saying send to direct address, whatever, and they can put the direct address.
But
Okay.
can they view the human readable version? Or do you generate a human readable that they can view like through the software? I would think that would be a good idea if you didn't, but
Okay. Yeah.
just so that they can
Have
take a
that.
look at what the human readable is going to look like before they send it.
Yeah, we can have that scoped out, Dennis. Yeah. For now, we just had the functionality, or we were planning to have the functionality to have just the send out option, but yeah, we can also have a human readable format before they send it.
Yeah, it was just as like a validation in case, they notice they made a mistake or something was wrong and they can fix it, or
Yep.
or
Cool.
adjust it.
Cool. Awesome. And so you guys generated a document, which we're going to see later. I know up until right before 10 a.m., we were still struggling with getting the direct message to go. Is that something we won't be able to show today, or you think we will be able to show?
I doubt if we'll be able to do it today
Okay.
because at least like from what I've seen, we've received the acknowledgement, but if the receiving end is not seeing it, then
Epic side is not seeing it.
yeah,
Yeah.
we would need more time to troubleshoot. Yeah.
And you
So
guys, are you working in a test environment or production addresses? Like eval?
test
Yeah.
environment, test
Yeah.
environment.
Yeah.
Yeah. So, and we're not going to have time to troubleshoot that right now. So we're going to have to take the challenges with the direct message actually getting through is going to have to be dealt with on another day. But I would like to switch over and have Epic be able to show us, or Jennifer, I don't know if you're going to show, or if it would be Evan or Eric or whoever is going to show the sandbox on the Epic side, just so we can get a feel for what would happen as a document was received via direct and how it gets into the Epic system. Do we have anyone from the Epic team or the um, THR team that could show the Epic side, the sandbox there?
I don't see anyone, Lisa, but Eric and Jennifer were planning on being here. And I will send a message to Eric.
Okay, so while we're maybe what we can do is shift back to that if they're able to join us. In the meantime, I think what we could do is dig in and take a look at the documents. Dennis or
Lisa,
anybody else,
Lisa,
did you have other questions for
yeah, Lisa,
Richard?
this is Jim Grew.
Yes,
J
Jim.
just a comment about the humanly readable C-CDA and our experience in eye care. So basically, when we talk to providers that have attempted to use direct messaging, there's so many issues that come up that if everything is blinded to them, if they can't see the process, they really can't resolve the issues. They get frustrated real quick and they don't use it. So one of the things we found in the eye care EHRs is when we allow the user that creates a C-CDA to actually have the human readable and be able to see what's in it, what that does with them is like they know what they want to send, but they don't necessarily know where to record it in the EHR. So by being able to see the humanly readable, they can record something, then look at the humanly readable and see if it's there. So it gives them a mechanism of controlling what goes in there and understanding it. And the same thing on the receiving end. If you can easily view those received C-CDAs, you know it's there. If you just go right to consuming it, it puts more mystery in the system. So my point is having the humanly readable available on both ends of the transaction really helps users be able to figure out a way to really use it.
Yeah. In addition to that, I would just comment, and I don't know, I see Scott Stewie there, like I would also recommend adding a validator. So I don't think they're putting out the schematron version, so that's why I'm interested in what John Demore was doing, but with getting the schematron from the CDA3. But I also believe a validator should be in there, and that's the other thing. The quality of the C-CDAs being sent into care quality and some of even the TEFCA exchanges, they're not, to me, they're not always valid C-CDAs. And I think having the ability to score what you're going to send to an external system or somebody else would be useful.
Let me add to that. What Dennis is saying, I hear that every single day. So somebody attempts to communicate with somebody else, it fails, then they either give up, or if they try to do something, the only people they know to contact are the health system that they're trying to communicate with. So it's somebody there that doesn't necessarily have the ability to evaluate the quality of the C-CDA either. And you just get into this argument, no, it's your fault, no, it's your fault type of thing. And then that it ends at that point. We almost never observe where the end users track the problem back far enough to get a resolution to it. So the people that are supplying it never hear that.
Yeah, and I'm not saying
it's too divided.
It's too divided, and
Yeah.
I'm not saying we need a complicated process. Just to like that scorecard that
Yes.
they had on the site, the e-testing tools was great because we downloaded and embedded it, and it gives you a score like 80%. It's an A plus or a B or a C. That was perfect. But anything more than that might be too much for a user. But the quality of the documents you're sending is just as important as building them.
Yeah, I would say that almost everybody that I'm aware of in eye care that has successfully begun using direct messaging used that tool, and the scorecard is what led them to be able to resolve the issue and or get to the right people that could resolve it. So again, having that, like Dennis said, is just, I think, critical to user acceptance.
Awesome. Really helpful comments. And, we'll have to deal with transport a little bit more.
Yeah.
It's hard. This is a hard problem, and there are many places that are hard. And transport is one of them. But as you heard from my presentation yesterday, not enough focus on the transport is one of the
It's
reasons
given.
we're having
Yeah.
lousy outcomes. After a lot of hard work goes into making decent documents, the weak link in the chain is often the way that the query is processed or the way that the push transaction happens or doesn't happen, and how hard it is to troubleshoot why. Okay, so let's shift gears. So if you guys are staying up with the idea of keeping, some notes about this, this tab in the Excel document has a place where we can write down some things that we observed. And maybe Richard, if you're still here, was there any data, in the small set that we were focused on, was there any data that we asked for in this demonstration, which you just said, you know what, that's just not available in the ECW. We don't put it out in our PDFs. It's nothing that we collect. Or was all the data something that you do actually still have in your, already have in your system?
So I think there was one piece, Lisa. I think there was a data point for determination method. I think it was related to how was the patient identified that they were pregnant.
Yeah.
So I wasn't sure because there's no clear data point that is being captured today in ECW for that.
Mm-hmm.
Do have data points like saying when was the ultrasound done. So would that
Yes. If that
for that?
ultrasound was used to determine, then you'd have the ability to say that the ultrasound was the method. And we can, if you look at the PowerPoint presentation that we provided, I kept all of the detailed slides back here in the reference materials. And we did really, David and Matthew and Michaela did a great job of helping to lay out what each of these entries looks like. And the estimated, let's see, is it estimated date of delivery has a method plus the sort of the notion of that the estimated date of delivery was determined by using some method, and the value set that is listed at value set 3 right here, estimated date of delivery. Now for pregnancy method, the method of determining the pregnancy, if that was, sorry if I wasn't listening clearly enough, value set number 1, pregnancy status determination method, there's a value set specified for that as well. So if ECW wanted to begin to collect this information in their UI and hold it in their database, this set of codes right here would give you instruction on what the options are and what to keep track of.
Yeah, because I wouldn't think that the ultrasound would have been the first determination, because you can't do an ultrasound until after 7 or 8 weeks. So the first sign would have been, maybe they
Blood
did like
test,
a home test, and then the blood
urine.
test, so your beta HCG
Yep.
would be the actual first indicator that you're pregnant, and then the ultrasound would continue, checking the development of the,
If we were doing that in eye care, though, like there's a lot of conditions. There's no specific test for the condition. You have to do a bunch of things, and then the provider makes the determination. So when the provider makes the determination, they put it in the problem list. So we would use the problem list to say the provider determined the person was pregnant. We wouldn't specify a specific test for it.
Absolutely. Yeah, you wouldn't. That would come, you would get the lab results. It would come from the lab results. That would be the first. So the beta
Right, but
And
it would
ECG,
be
yeah,
the
yeah,
bunch of things. The provider says, "Yep, you feel like you're pregnant. You look like you're pregnant. The lab says you're pregnant. You're
but
pregnant."
that's
Right?
some of the option though, Jim, in that
Yeah.
value set, and I can call the value set up if we need to, but of palpation of the abdomen,
Right.
examination of the vagina. There's other like
Right.
examination things that could be the method of determining pregnancy, along with urine and blood and some other ones. So
So I would
So,
just suggest that trying to define a method of it gives a level of complexity that I don't know what that brings to it. If that kind of takes the provider out of it. The provider really is the one that's making the determination with everything they're looking at that the pregnancy is there, and their indication is they added it to the problem list. That's by far the simplest.
I think there's two pieces of this that we're looking at right now. I think there is evidence and a method from what I'm understanding is
That
that
makes sense. Yes.
you have the method could just be I took a blood test. Method could be with like a test, but the evidence is the positive test or the conditions or the problems that the provider puts into the problem list. So maybe this is more of a question of if you have this pregnancy status, you have a pregnancy status method and a pregnancy status evidence. And they may overlap or they may not overlap, but at the very least, there are pretty established method. It's well understood that, like, at least in the terminology space, that method is basically I took an ultrasound, I did an examination, palpation, that's what the value set is. But maybe it's just a consideration of that we need to potentially bind some evidence to that
Yeah.
observation.
that makes sense. So does the value set, I never looked at the value set, Lisa, so
Here's,
does
I
it
just brought it
actually,
up on the screen
yeah,
there.
I see that.
So I guess what I'm having trouble with is the purpose. If the purpose is that this is you're sending them somewhere to, because the question is the patient really pregnant? Then I see this as being important. But if this is aftercare and the pregnancy is well established, why is all of this even important to transmit?
This is the patient pregnant? So this is in the history of present illness. There's a basic pregnancy status observation. And in this status observation, you say, if the pregnant, this value tells you right now here, if the patient is pregnant or not pregnant, possibly pregnant, there's a few different concepts that go in there. And if the patient is pregnant, well, even if they're not pregnant, the method code could be you did a urine test and it said for sure the patient is not pregnant. This is the highest level entry that when you ask somebody the question, is there any possibility that you could be pregnant or are you pregnant? This is the entry that holds that information.
Okay.
And I would say the importance of it is that, you know, especially if it's in like, we want to make sure that the pregnancy status is an item that is held throughout all documentation in the standard way. In a summary document, you want to know the strength of that pregnancy status. So if pregnancy status is yes, and it's patient reported, the patient just says, I think I'm pregnant, then the provider can determine that maybe I need to confirm that. Or if it says, or if the pregnancy status says yes, and the method is through a blood test or an ultrasound, that's a stronger evidence to say, yeah, that is to confirm that they're definitely pregnant. And I think that we're looking at something in a progress note that we're thinking is like a progress note thing, but we want to make sure that the pregnancy status itself in a summary document or in any form of document is the same. So I think that's
That
part
makes
of
sense. I can
Uh,
definitively tell you can't tell if you're pregnant by looking in the eye.
Uh,
Yes, yes.
Hey,
And
Lisa, Eric from Epic is on the line right now, and I know we have limited time, so this is fascinating conversation, but I wanted to kind of refocus us. Eric is on the line.
thank you very much. Eric, are you in a position to be able to show us inside the Epic EHR and give us a sense of what the workflow might look like if you were receiving a new document for this?
No, I don't have access. I don't think we've been able to successfully find these documents that they've tried to send to THR.
Yeah. Do you, in the sandbox environment though that we set up for the testing today, do you have the ability to show any documents in the document list for Mimi, sort of what the destination goal is?
I don't have examples like that at the ready.
No. Okay. Okay. You know, I
I'll be
don't
able
have
to
any
give
other
wondering-
ideas about how to work through that. Catherine, do you have a suggestion?
I have a thought. Richard, do you think you can trigger another direct message while we're all here together?
I think we'd also want somebody from THR because my security in their system is not probably what we would need it to do for this demo like that.
Okay.
Dennis, could we receive it on our system?
I know that if you have production addresses and I think you have the Bell, you could receive it, but you know, I
And view
haven't
it?
done anything in the Akiko system to.
You wouldn't be able to view it. It
No.
wouldn't
Well,
put
you
a
could
template
view
on.
it. We can view any C-CDA that comes through.
Yeah.
But
Would that have
that's
any
about
value?
it.
Would it have any value of it just being viewable, Lisa?
No, I don't think so because I'm going to show the document here anyway. So,
Okay.
you know, we'll have to pretend like it made it and we'll just look at it as if it did arrive. We won't be able to look at any of the functional requirements around if the document's metadata is being used accurately to show the users on the receiving side what kind of document it is, who the author was, what the title of the document was, some of the labeling that we're aiming to have improved so that Samantha, when she shows up at THR would be able to easily find the document that she's looking for. I think what I would like to do is to, to be back on track. And Jim, I know it's hard probably not to compare this to eye care stuff, but in order to save time for the maternal health focus of this track, I would like to be able to focus in on the maternal health content as it was specified, look at what was available, what was able to be documented, less sort of debating if the standards are right or wrong, but just looking at how they have been expressed to exchange the data in the formats that we have. So what I have up on my screen is I have two tabs right here. I'm going to close this value set authority center tab, and these are the human readable renderings of two documents. This document, which I'll put first, document A, sample A, is what we have today. And this is what ECW was able to produce for the Mammy shell example. And you can see the sections of the document: allergies, results, reason for referral, reason for visit, medications, immunization, social history, problems, vitals, procedures, encounters. I'm looking for a pregnancy section or a history of present illness.
You might want to go all the way down, Lisa.
Okay. Procedures, progress note, history and physical notes, history of present illness. So here's the history of present illness section, and it's got a clearly laid out subsection where the pregnancy status is revealed, the start date of the pregnancy, the end date of the pregnancy, which is not filled in because Mammy is still pregnant, the pregnancy determination date, which Richard just brought, up as an example of something that we had questions about. How would we deal with that? And then an estimated due date populated in here in the pregnancy status. And in the pregnancy summary organizer, you can see the gravida and the para numbers. Mammy is pregnant. This is her third pregnancy. And 2 babies were born over 20 weeks. That's what the para number gives you. In terms of her past medical history, in the pregnancy section, there's information that was up until November 3rd of 2022. I think that was probably around the time that they determined that she was pregnant for the third time. So up until then, she had been pregnant twice, and both of those babies were born after longer than 20 weeks. So this is showing that complex wrinkle that we talked about yesterday. It does not bring up the question of should pregnancy information, in the history of present illness, should pregnancy information show up on the patient's problem list? And that is not a topic that we brought up. It's something maybe we could spend a couple of minutes looking at, but if we look at it here, we didn't ask for it to be in the problem list, and that's probably, I don't know, Richard, if you have any sense of, in an uncontrolled experiment like this, when you're actually in production, if you made a progress note for a pregnant woman, would her pregnancy appear also in the problem list?
So the problems that you see here are all ICD codes. So as long as they add an ICD code under the problem section, it would show up here.
Mm-hmm.
Not any structured data that is not linked to an ICD code. That would not show up here.
Okay. I think that's a good question or finding to note. All the students who are working with us are taking notes for me because I'm having trouble doing so many things at the same time. So let's just take a note about discussing or being clearer about if if a current pregnancy should be expected to be found on the problem list.
I have a question,
Yes.
Lisa. They may or may not document a current pregnancy on the problem list, but there are certain problems that are associated with pregnancy that might be documented. So like if someone comes in and with a miscarriage, right? that would likely be documented as a problem, and especially because it's considered a miscarriage, it would not be documented in the pregnancy history, I think. So like there are conditions that are associated with pregnancy that someone should probably look through to see if that results in a pregnancy status or gestational diabetes from Scott that will be in the problem list that could trigger the concept that they have to be pregnant and how that coincides with the missing pregnancy status. I think that's, sorry, I'm a little scattered today, but I think that's something that also needs to be taken into consideration as well.
Yeah, yeah. So the whole interplay between information in the problem section and information
Right.
in the pregnancy section, I think we should
Would
look
be
at
important.
that a
Yeah,
little
that's what I was
more.
thinking. Because if there is an entry in the problem list, wouldn't you'd want an entity relationship between the problem and the pregnancy section, would you not?
That's
Probably.
a complex connection that could be described in the data for sure. For
Yeah.
sure. So this is the sample B that we produced, kind of going into this experiment today. And we were able to share some of this information with ECW. So you can see that the human readable layout is nearly identical. And so where we'll be checking if the machine processable entries look like they're recorded the same way, but you can see that it was pretty easy for ECW to produce human readable information that made sense according to the design that we had asked for. And so I just wanted to show. And Richard, did you have a chance? Was that helpful as an implementer to receive more specific guidance about how the information that you're coughing up out of the system as data, how it should be presented in the human readable section? Did that help?
Yes, that was a lot of help, Lisa. Thank you for that. Yeah. Otherwise, it'll be difficult to understand like what the expectation was. Yeah.
Yep, yep. So I think that was an opportunity to kind of see that was a good thing that we did. Now let's take a look inside. I just wanted to focus on pregnancy information. There's a ton of information in here, and our scenario did get into examples of things in lots of the other sections. But just because we're going to be short on time, I want to now shift gears and look at the top 3 spots that we wanted to look at in the header, and then look at a little bit of some of the entries that are represented inside the XML and get a sense for that. So this is the sample A. This is the sample that came from ECW that I just rendered for you. And I'm just going to make it a little bit bigger for your eyes to be easier to see. And I wanted to compare to sample B on the metadata. That's the key stuff for labeling these documents when they are exchanged among systems. And so over here, we have some template assertions that tell us what kind of document template we've got. And there aren't comments in here, but I'm recognizing these OIDs. If you take just a kind of a quick notion to take a look at what the tail end of the OIDs are, and compare it to what we've got over here. I might even be able to do window tile vertical. That might be an easier way to do it. So now I've got them on the wrong sides though. All right, so A is on the right and B is on the left. But here we asked for the document to be represented as a progress note. And this looks dicey to me here. This looks to me like the same set of templates as these.
It did. It didn't put out the 1.2. Interesting. Why didn't it not do that? That's probably not a typo. It probably, when it generated, it put out the wrong code.
Put out the
Yeah,
wrong.
it should be a
You might want
1.2.
to take a look at
Absolutely.
that.
Yeah.
You might want to take a look at that. So ECW nailed it with the progress note template, and these template IDs are all expressed inside consolidated CDA. This is what ties you back to the actual guidance. If you were to look in consolidated CDA and say, if I want to use a progress note template, how do I tell the machine that that's what I'm doing? And the way that you do this, progress note, clinical document, here's the OID that should be asserted to say it's a progress note. So I think that both of our documents got this wrong.
Yeah, we didn't put out the 1.9.
I won't touch yours. I'll just put this in the comments over
Yeah.
here. This should have been a progress note template, and the correct template to assert would have
That
been this one with this extension.
I think I
So
must have got that sort of mixed up when we were trying to put out a progress note, but make it an antepartum summary
yeah.
at the same time. And I think that's, it's not a common occurrence to do that. So that makes sense.
Yep, yep. Okay, so this tells the validators, this tells everything else. What kind of template are we packaging the information in? So we need that for progress note. Now, the next thing that we wanted to do is we wanted to make sure that we were telling machines that this is an antepartum note. So its LOINC document code is this 57055-6. Let's see what we got over here. All right, that part was done. So, but for the packaging of the template, the document type is coded correctly. The next thing that you want to see is a title that is consistent with that type, which they've both got. And then the creation date, which we asked to, I don't know, this says it was created on July 16th at 4:45. This also, I noticed, Richard, in some of the documentation in the scenario that we asked for it to be generated sometime earlier than that. I did
Oh,
want to mention to the
yeah.
crew that getting sample documents to come out at story prescribed times is one of the hardest things that you have to do when you're working with synthetic data. But the important thing for me that I like to see here is that there's a sense of the time zone that we were in when this document, what, the sort of the relevant time zone, because a lot of times time can come out in a really weird way. And if this is just a UTC, with a -0000, then it's very difficult to understand. You might be seeing stuff like a test was performed in the middle of the night. It's just very, very difficult if the temporal aspect isn't correct.
Isn't there? Yeah.
Okay, any other comments there? Okay, so the next thing that we wanted to look at is we had put some specifications out that we wanted this synthetic information about Mammy Shell to have a certain address, and this has to do with patient matching. And it could be even that the patient registration information that's over at the hospital in that sandbox system for fake patient Mammy is not matching with the patient information for the document that's being sent. We really don't know right now what's causing the inability to ingest the document that appears to be sent correctly, but the demographics of the patient is important to be for the document to be recognized by the receiving system. And so let's just see how we did here in our what we've got today. We've got a patient, we've got the addresses written correctly, we've got a matching phone number and telecom, the patient's name, administrative gender, all of those, what I'll call demographic details that affect some kind of a patient matching type of solution are all entered correctly according to the scenario. And then we asked for a little bit of exploration in this area of language and communication. We are thinking about that with US-CDI right now. And so we asked for the information to be shared that Mammy's spoken and what was it, spoken and, I gotta go back.
Express spoken, and I thought it was in the, what was the other part?
We wanted
had
to say both express
both
spoken
expressed
and
and
express
written.
written in English. The proficiency level was good, and that English was her preferred language. And so in the XML, to say that in the sample that we put, it looks like we've got
It's
English.
two. I put two entries. So the first entry is the spoken and the second entry is the written. I wasn't
Oh, there we
sure
go.
how, yeah, you're allowed to put in multiple language communications because each of them are unique with their code sets. So
There we go. And that's how you would have to do it to say two things. You have to repeat this block of XML once for the express spoken and once for the expressed written. Interesting.
right.
And
Yeah.
let's see how ECW, Richard, do you know if proficiency level is something that ECW even gathers?
We don't, Lisa, at this point, but we are in the process of enhancing that to accommodate for the US CDI.
Okay, so proficiency level would be another thing that we'd want to list in that column of stuff that currently the EHR is working to grab, but right now they don't have a spot for that. It's impossible to expect exchange of data elements that the systems don't yet
Doesn't
collect.
exist. Yeah, to be fair, I was able to add it to the tool, but I wasn't able to put it in an EHR either because I haven't seen an EHR that has all that data, like the proficiency level.
Excellent, excellent. Okay, so I'm going to take, so the longest I wanted to go was to about 10 minutes after 12 to be digging in on things like this. So let's move out of the header and jump down into the body, the structured body of the document, and let's take a look at some of the machine processable entries that go along with the human readable. So I will skip in our sample A down to, I'm just going to collapse down to the structured body. That's how you know you're out of the header and into the structured body. And I'm going to collapse the sections that are about other things, which I'm going to have a lot of sections to collapse here.
Yeah, sorry, Lisa, I had that at the bottom, the last component.
Yeah. Maybe I'll just zoom way down here to make it faster. I'm going to search for pregnancy.
So the component in these will be C-CDA would be similar to yours, I believe, because again, not everything is coming from the HR, right? Because this is not developed in the HR to begin with. This is more on the generation side of things for the C-CDA.
Right.
So did you have to do manual creation of this XML, Richard, or was ECW in a position of knowing how to generate for example, a pregnancy status observation?
No, it was all manual.
Yep.
So yeah, this was something I manually updated the document.
Okay. And so you use the spec, that's how you tell what fields to include and where to put stuff.
Correct. Yeah.
Yep.
Based on the IG that
Yep.
you yeah, that's how I developed this. Yeah.
Okay, super. So it's still early days for teaching EHRs how to spit out the machine processable data. Are our Epic folks still on the line? Eric, maybe you could just comment in terms of would any machine processable data from the document actually be used beyond maybe what's in the header or what's in the metadata of the message? Today, would any of these entries actually be consumed by the system anyway on the Epic side?
Well, we would render it all so that a physician could see all the stuff as far as the stuff that we might programmatically try to use. We
Yep.
would parse out problems, meds, allergies, immunizations are the big ones. But as far as I don't think there's anything that would take it in and pull in like a pregnancy observation or
right, right.
Yeah.
Two
And
separate.
that's pretty typical of most EHRs. I thought maybe Epic would do a lot more sections, but that's the one thing that really irks me with certification is, you know, they build all this stuff in for since 2010 and 2008, and we put all this data in, but nobody consumes anything but the problems, medication, allergies, immunizations, and a few other simple sections. It's just,
I'd like to underscore that because the amount of effort that goes into trying to make interoperability go and the amount of what it's good, effectiveness of all that effort is largely being wasted right now. I know from Karishma and Samantha's point of view, if they could see documents where the information was as readable as this, where they got sections that could spit out, where was it? Pregnancy section, and have the information in there, it would make such a difference.
Yeah.
And this level of advancement can come more readily than all of the work that has to be done to craft these machine processable entries, which to some extent don't get used when they get to the other side anyway.
well, they have to have a place to put them, right? So you get data from EHRs, and not all EHRs have all the same structured data elements. So you're right, making the view is significantly more important, you know, when you're sending it to somebody else for visual consumption, I guess, rather than electronic. But your point, Lisa, is like we do lab results, and we implemented done ton of different sections. But if we're following the reusable patterns, like lab results and things like that, where you're already some people are already processing those and putting them in, like result organizer, result observation. If we're following the patterns like we did for the eye care, it shouldn't be a massive step to then incorporate that. The only difference would be you have to have a place to put it.
Yes, and that is a much harder problem, because you have to ready your database. But I just think that in terms of accelerating progress, if you look at this problem as being, let's say, two main pieces, where the first thing is you want to acknowledge that this data needs to be captured in your EHR, so you have to make a UI that can handle it and a database that can hold it. Then maybe three pieces, and then there's the idea that you just need to release it so that the receiving system can see it and interact with it, view it, learn from it. Then the third piece can be that subsequently, receiving systems have to ready themselves to do something when it's appropriate with the processable data, if that makes sense. And so I just hate to see everybody delay because you can't do all three parts. And I think that obviously when the data is needed, you have to start gathering it. That's the first step. The second step is to share it with others, which means rendering it in these documents. The content creator still has the responsibility of putting the information that's in their database out in a structured way, but just to be rendered so that the humans can easily see it. It looks pretty structured, when you look at how the labels are laid down, and I tend to anchor my text right from the start to make it easier to hang the process stuff on top of it. But this text element is what's rendered by the style sheet to produce what most people think of when they think of seeing a CDA. That's just looking at that rendered sort of tableized or list organized information for the human to see it. And then the third step is to start making machine processable entries for information that the guys who you're sharing with will actually be doing something with. And if the receiving system isn't doing anything with the information, then you're really putting a lot of extra cost into your development for no reason if nobody's consuming it on the other side.
Yeah. Yeah. Scott said something important. HTI2 is going to make a difference. I mean, because now with US CDI now moving forward, and when you have to have the provenance, and you have to have provenance levels into multiple, if it's more than just the first provenance level, and you have to go deeper in order to be able to maintain those IDs and send the right provenance out, you have to consume it and track it. So EHRs are gonna have to start storing more of this information, and like the IDs. I thought you were gonna give a thing on IDs. I guess you haven't done that yet,
IDs
but
is later on. IDs
oh,
is
it's later
later
on.
on today.
So
Yeah.
even the IDs, like when a document is generated and all the problems have IDs, we need to store the IDs for problems that were recorded by other providers, so that when you reproduce the document, you're putting the same ID back in, not randomly generated IDs from the EHR, which many systems do. I mean, Epic's super big, so I don't know if they do it or not, but I mean, a lot of the smaller EHRs just don't have a good concept for that. And as the certification and the spirit of being able to share and interrupt, all these digital data and the structured fields, it's going to be expected that you can import them. And
Yeah.
then,
Lisa, I just,
you have to have a place to put them.
Yeah.
I do want
Yes,
to push back on the notion that it's not valuable to get the data, even if it's just rendered. I think, particularly if you can tell that this is an antepartum report, and you can see that as separate from the transitions of care you received on this patient for all sorts of other circumstances. This, I think, you can immediately get to what you're looking for, and it renders reasonably. I think it immediately has value, even before incorporation is possible. I think, and a lot of the incorporation stuff, it is a question mark for some providers whether or not they want to incorporate information from external sources, even if it were possible. And so I think it's getting at least the ability to view it, and getting the trust that this stuff is available and viewable first.
Yeah.
Oh, absolutely. Absolutely. And I
Yeah.
think the viewable is what Lisa's trying to point out. Like, most systems aren't going to be consuming it. And the view, when you're sending it, to the hospital for the pregnancy, she's giving birth, they need the information. They want it in a format that's going to just make sense. So no, I agree. It's just, we're going through all these validations and all this stuff to make sure the data gets in properly so it can be consumed, and then nobody's consuming it. I think that is secondary, but I still think it's going to become important at some point, especially if
It
we're
will at
required
some
to go
point.
down multiple levels of provenance.
Yes.
Once you have to
And
start tracking multiple levels, it's imperative that you have the electronic data.
it will, but Dennis, if we're looking at 2028, 2030, we're starting to look at when will US CDI have data elements like the maternal health data elements in it, that would then make it so that by then systems obviously will have to be able to ingest and process the data. We don't want to have to wait until then to start sharing the information. And I'm just trying to make it visible that it would be possible to start sharing more, at least
Yeah,
anything that's in your EHR, you should be able to share today as
true. But that's where
legitimately
Scott's right,
organized human
though.
readable text,
Yeah,
and
that's where
start
Scott's
there.
right. You could just put the narrative in, though, the human readable text, and leave out the digital entries, and it's still important, and it's
That's right.
still
And then you
usable.
just keep working on your digital entries, keep pace with US CDI, do what you need to, but don't wait to share information that's already inside your system, that you already have, that you could be sharing.
Yeah, I mean, when you're talking about, when you gave your presentation about fire, and I don't want to sidetrack it, so I don't want to
Yeah.
hijack. So go ahead.
And I'm getting close on the time that we need to shift. And we are going to kind of like share what we learned and insights like that. So maybe your comments can come in a couple of minutes. But I just wanted to ask if anybody had, we offered some lab result insight from the scenario, a little bit of vital sign stuff. Maybe I can just take the last 2 minutes and wet your whistle a little bit with what else is possible to take a look at in these documents. And then you all have access to these samples from downloading them from the IAT. And so what I'll do over here on the document that I'm a little bit more familiar with, I'm just going to bring you down to an area like the results section and bring up a point just to call back to some things that we've learned in previous IATs. And this is the kind of thing where I'm hoping that we can that some of these learnings can stick. Catherine brought an example to us of the problems with discharge summaries when lab results and procedures were just big kitchen sinks of sections that had everything dumped in it. This is like a common theme that she's brought to us. And we agreed that it's possible to organize your results section into 3 buckets: lab results, imaging results, and then any other kind of results that come along. And so here we've got a document that is not doing that. We've got the lab results section right here. And then, and you can see the code on this results section 30954-2. And then we've got another, let me see if I can just close it at section, an imaging results section right here that's coded in the same way. It says, its title says imaging results, but it's coded like another results section. I think that this is going to give us validation problems because at the high level, it looks like we've got 2 results sections, and the spec says we should have 0 or 1. And so I wanted to kind of point out that we need to still be mindful of the things that we've learned before about how to do this. So what we've learned is that documents will validate if you put a single result section and then you make 3 subsections. And we've offered the LOINC codes for the LOINC code that would be a laboratory subsection underneath results, and an imaging, diagnostic imaging underneath results, and then other results underneath results, and it gets through the validator, or something like this of producing multiple high-level result sections, I think will give us validation problems.
Yeah, I don't think it did, but that's a good point. I think
Yep.
when we originally did the imaging results, we were doing them as 2 sections. This goes way back because we don't do a lot of imaging, like in terms of putting eye images into the documents, but we
Yep.
did it because it was required.
Yep. And then while I'm here, because while I'm taking some pressure off from everything has to have machine processable entries, I do think that getting codes right from the top down, the right codes for the document, the right templates for the document, the right codes for the section, there's stuff that information, semantics that's carried on a section by section basis. And when we look at mother and child, maternal health kind of scenarios, there's sophistication that needs to be understood about how you can even express at the section level, whether this is a section of level information about the mother or section level information about the baby. And it's something that IHE and the profiles that Andrea is familiar with and has worked on at IHE has given us patterns to know how to do. And it's something that I've not seen done anywhere else. But it would be worthwhile for us as a community, if we want to get more adept at doing maternal health types of data sharing, to learn how it is that you can make a section about a different subject. And neither of these documents are showing that. We put it into our requirements and we knew it was a stretch ask. I think that probably for next steps, as we move on from here, that should be listed as another next step, is
Good
to
point, yeah.
advance our sample to show people examples of how you make like a plan of care section that's about the baby, and maybe put the information about the future pediatrician for the child in a section that's clearly labeled
That's clearly for the
about
baby.
the
Yeah,
baby.
that's right. You did actually have that in there. I didn't have the time to split that out, but that's a good point.
Yeah.
That
Lisa,
subsections are going to be key. Like, it makes sense that you would have lab results, image results in the same section, right? You wouldn't want to split them out. I guess that's just a My generator is it's too new.
Yeah, it's
not
new.
smart enough to do any of that stuff.
Like
So
Matt said,
I
it's
had
a
to
great
concentrate
idea.
on the important things, and I didn't concentrate on the stuff I didn't have time for.
And Lisa,
Yeah, no.
just a general observation, in CCDAs that we've received, we've seen the results section kind of used as kind of a garbage can where people stick almost anything you can think of that they don't know where to put somewhere. And a lot of that probably should go in the physical exam section. So just a comment about there's not a lot of guidance on what the limits that you put in the results section are.
I want to find my slide about learnings, key findings. This will be good. So now is my time for me to stop talking and for you guys to get a chance to talk a little bit more. Think about the things that we brought up so far, maybe key takeaways that we want to have. For the one that you just said, Jim, I'm just going to note that results section limits to what belongs.
Yeah, and an example of that, just to clarify what he's saying, like nobody really had a way of putting in a refraction or the visual acuities into the document because it wasn't really described where and how it should go, which is what we tried to do with the eye care. They would just take those results, find the LOINC codes that matched, and they would just dump all of the refraction in individual entries in the results section. So many EHRs are just implementing things that work for them. And so it's new, right? It's new territory, right?
And I got this one, make examples of a section about the baby inside a document about the mom. That's one. What other kinds of things do you think we should have as takeaways from this experiment?
So one thing, Lisa, that at least I think this was brought up yesterday, but I just wanted to point out that I also saw some lab results that we were expecting to be part of the antepartum document. But currently the way the way ECW has results, lab results and the results component is basically on the LOINC code that is mapped in the EHR. Right, so I think we talked about this yesterday, where how do we standardize the LOINC mappings, because everyone has their own way of mapping a LOINC to a lab or a lab attribute. So I don't know how that flies when the consumer is expecting a specific lab result and they're looking for a LOINC code, but the sender mapped it to some other LOINC code and I'm able to find it in the C-CDA. So I don't know, like that.
Well, that's another big topic, I think, Lisa, that, you know, where they're talking about clinical lab results versus other types of lab results. Richard, I think even with HbA1c, you know, there's like 25 different LOINC codes, and I'm just guessing. I don't know if there's a bunch. Which one did they use? Was it serum? Was it plasma? There's like so many different LOINC codes you could use to represent a test. Is the right one being picked? That's another challenge that the structured docs and teams have had.
And is it right to say, I don't know if I don't think Samantha or Karishma are here today, but maybe anybody who has exposure to the clinical side, that many of the maternal health data elements have this sort of lab aspect to them. It seemed like, at least when we asked what were all the key elements, the portion of key elements that were lab related was really a big piece of the pie.
Yeah, well, they have to do the syphilis screening, you know, gonorrhea screening, Hep B. There's a bunch of different screenings. And I think to Richard's point, you know, we picked specific LOINC codes we wanted to use. In your system, Richard, can you search by LOINC code or as well as description, or is it just description? But I mean, the bottom line is what he's saying is that it's possible for you to potentially pick a different LOINC code that has this similar description. It might not be exactly the one that you wanted.
Yeah, so we have the capability of doing both, Dennis, to look up by description and code, but it all depends on the user, on the EHR user who is actually mapping those LOINCs to their lab
Right.
So yeah. So sometimes they might have documented, they might have resulted the lab, but the consumer is looking for some other link and they're not able to see it.
Right.
All right, I got the relationship between the pregnancy section and the problem list, which we really didn't talk at all about before. I just kind of brought that up today. What
Yeah.
else comes to mind? Something about transport. I mean, transport is a hard
It's
is a
the
hard.
tricky one. That's even when we were trying to do a demo, Lisa, with the eye care between Crystal PM and a couple other eye care ones, we struggled in that area, getting the documents to go in the testing environment. Like even Scott put a comment in there. It's challenging. It can be challenging. There's a number of reasons why it might not work. But I think even in production use, I think the transport has been a key source of problems for in eye care for a lot of our providers. Like getting a getting an XDM package. Some EHRs don't support XDM, so they can't even understand it. In your case, it was determined that you would both sides supported it, but not
No,
everybody
it didn't
supports
turn out
XDM.
that way. It didn't
Oh,
turn out that way. So Richard, the message that you sent to Epic was not with an XDM package, right?
Correct.
oh, right, okay.
And we still don't know if that's the problem or not the problem.
But either way, like all systems should be able to support an XDM as well as a standalone XML or C-CDA. Like that shouldn't be locked into one standard.
But I think the standard still includes an or. That we talked about that
It's an
last
or, yeah.
time. It should
When
be in the
you
end. Everybody should be able to support both.
well,
And
the
then you get rid
problem
of
is
this
there's
problem.
two measures, Jim, H1 and H2. One
I
of them
know. All I'm
supports
saying,
XDM and the other one doesn't.
all I'm saying is the standard allows you to choose and they don't match up. So until you align those, there's going to be problems. All I'm saying is
Well,
it should be aligned in the regulation.
a C-CDA should be enough for any EHR that is certified to accept.
Exactly.
It should be
Yeah.
enough. XDM should not be a requirement.
Absolutely.
But the
That's the
problem,
base. You're right.
but the problem is there's a lot of systems that only send out XDMs. So the ones that only accept C-CDAs can't do it. It doesn't
Well,
work. That's what Breck's saying.
that's Scott's right. Whether it's H1 or H2, the only difference between the two is the edge protocols and the XDM. You have to support C-CDA in both of them. So if any EHR is not capable of receiving just a standard C-CDA,
But it's
then
not the receiving that's the problem. It's the
Yeah.
end. It's everybody can receive the problem is then
Jim
sending it.
and Dennis,
They
for a
cannot
minute,
send
I
it
just
that way.
want to ask the
Yeah.
maternal health folks if there was anything else in terms of what their expectations were around what we would learn from this exercise today. Catherine, the team from THSA, what's your sensation of putting it all together and seeing the sort of the state of the challenges in the conversation, what we're looking at?
Well, I actually feel pretty good about things. I think that given a little bit more time, that ECW and Epic would have been able to figure out the wrinkles between sending and receiving the messages. One of the problems we had, which is a beautiful problem, is that we started this project and we engaged Lisa, and then the HL7 IAT was coming up quickly. So we were quickly getting things done. And so I feel energized, and that given just even a month more, Lisa, that we would have been able to figure out exactly what was creating the issue with the handoff, because I know ECW and I know Epic can both send and receive a direct secure message. Why this isn't hitting the right spot, I don't know yet, but given a little bit of time, an hour together, I think we could have figured it out. And I think that all this guessing and maybe this or maybe that, I mean, I don't know, but I do know both EHR vendors receive direct secure messages. I've seen them with THR and ECW. So that's not the issue. I know that ECW shares of C-CDAs to carry quality, and Epic picks them up. I know that happens. And so I think we're very, very close.
Yeah, that's a good point. You're right. That's a fair
I-
statement. And I mean, it is a
I-
testing environment, and testing environments are not always set up very well. And so obviously in production, it works well.
And Dennis, everyone did this in their full and had full-time gigs.
Yeah. Oh yeah, of course. Yeah, you're right. The timing, that's actually a very good point. You know, we always get to the last month or something, and that's when, you know, we start getting ready for the IAT. So no, that's a fair point.
No, and a lot of it was, and thank goodness, and we're so thankful that Lisa took us under her wing and helped us through this. But we actually didn't start like really formalizing what we thought were clinical contents until later on in the process.
Yeah, I would have to agree. I think it has been a success. And you do expect to run into problems and things come up when you're testing. And I think from the point of view of what you were trying to achieve, are you happy with the results?
I
And the
am.
answer is yes. Yeah.
I am happy. I looked at what ECW Richard showed, and that and I was comfortable that yes, that ECW can produce this document. And I believe that if ECW can produce this document, that Epic will be able to ingest it.
You know, I think that we just this is a reality check, and Richard, I want to run it by you, but for Richard to have produced the scenario data manually in the XML file, I'd like to go back to the statement that ECW can produce this document. I definitely think ECW has the potential to produce this document, but I think there would be some next steps work that would need to take this experiment back to ECW as an organization to be able to say, this work proved that people were excited about trying to have this, receiving information like this, that this would, you know, make lives better for the folks who came to us in the first place and said, we can't get what we need. We're having to go back and ask for faxes. So I think that as a next step, we would need to probably take stock with our EHR participant partners to say, where do we go from a test, from a demonstration, a very small scale sort of iteration on this, to say, how do we really make it real so that you guys, production systems can spit out data like this?
Right. So I think couple of next steps, Lisa, at least from my end. One is to get the communication going on with Epic, so we're able to send these transactions successfully. I think parallelly, I'd be taking this back to the EHR team and trying to get whatever data points that we need for this document, and see how those data points can be added into the EHR so that users can start, you know, capturing that data so it's available for us to generate this document. So that discussion needs to start. And I mean, at this point, I don't have any timelines on what the cadence would be, because reviews need to happen, and then different product people have to be involved to see what is needed in the HR system. So so at least that's my next steps, to take this back to the HR team and get this work started on the data capturing standpoint.
Yeah, yeah. And do you think that you know, with a couple more days, a couple more weeks, like Catherine said, maybe put a little bit more time into troubleshooting what the problem is, and you know, maybe even by the next time that we get together for an IAT, which would give us a few months to work through issues, we could come back with an iteration that that tightens up some of the spots that we we identified today here that just need to be adjusted.
Yeah. Is Eric, Eric, are you the one from Epic I need to be coordinating this with, or?
Myself, and we'll want to include Evan from THR.
Okay. Okay. Yeah. Yeah. I can work with Eric and Evan and then
Awesome.
decide. Yeah.
Awesome.
All right, thank you. Now, I do want to ask, Eric, do you believe if ECW were to send the C-CDA, that Epic would be able to ingest it?
It should, but like I said, my gut says it's probably something that's, I can't remember who said it earlier. It's probably some kind of non-production environment thing. So I know a lot
Scott
of
did.
it's got to be
Yeah.
some kind of weird
Yeah,
things. That's probably just manual CC
we had
document.
the same problem trying to do it in the eval environment before, sending documents, even if they weren't XDM or XDM, it didn't matter. There was some minor, issues, especially if you're crossing evaluation systems, like different test systems.
Well, and test environments add health systems in particular are frequently not configured for use, because they're used when they're testing for pre-go live expectations and then mothballed. So
Yeah, exactly.
pulling them out of mothball, that's a hard thing to do. And for health systems, that you finding the people who even know how to pull those out of mothballs is hard. So it will probably take help from the vendor.
Awesome. Well, we're at time, and I wanted to thank Scott Stewie from Direct Trust for coming and participating today. Direct is an important protocol that we're all using to move data around the nation today, and it's something that I think is great to have a part of the IAT. Thank you for coming. Thank you, everyone, for participating, and we're going to head back to the main session.